Hi, Dr. Gullberg here, continuing our infectious disease series. Today we're going to talk about infectious or infective endocarditis, which is an infection of the endocardium. Primarily are the valves of the heart. Aortic valve and mitral valve are most commonly involved. The aortic valve generally being much more serious because of the higher pressure variance on each side of the valve versus mitral valve, but they're both obviously a big problem that you're going to see and take care of. We like to look at the Duke's criteria to make the diagnosis, which is divided into major and minor. The major criteria are generally going to be blood cultures that are positive 12 hours apart, a new vegetation on a echocardiogram. Of course, we like to use TEEs these days rather than TTEs because TTEs miss so many of them. Or if there's a new heart murmur or changing heart murmur on physical exam. The minor criteria, of course, are fever, signs of immunological phenomena such as renal insufficiency from glomerulonephritis or complement disease, or embolic phenomena, and if they have a high risk for endocarditis with a congenital valve problem, that type of thing. So we like basically two majors and a minor, or one major plus several minor criteria to make the diagnosis. Symptoms are generally going to be in acute patients, they're going to be acutely septic, maybe in septic shock. Patients with subacute endocarditis, which usually is going to present after 6 weeks of illness or up to a year and sometimes longer illness with just fever of unknown origin. Patients that have malaise and they're going to have high SED rates generally. So in terms of looking at the organisms here, acute endocarditis is usually going to be from staph, either MSSA or MRSA. Or beta strep, whereas the SBE is generally going to be related to alpha strep, such as the strep viridans group. We do see gram-negative rod endocarditis and fungal endocarditis and culture-negative endocarditis, but those are much rarer. Enterococcal endocarditis is we see also related to GU infections or GI infections, is extremely virulent endocarditis. Our complications of endocarditis include acute pulmonary edema or heart failure from destruction of the valve or perivalvular abscess, emboli to the brain or other parts of the body. Sometimes we'll see splinter hemorrhages, sometimes we'll see Janeway's lesions, sometimes we'll see Osler's nodes, and of course sometimes we'll just see plain stroke disease, which is obviously a miserable complication of endocarditis. Immunological phenomena are can also be seen with kidney insufficiency, elevations of the creatinine, and we can see, of course, hemolytic anemia as well. Treatment of choice is going to be a bactericidal antibiotic for at least 4 to 6 weeks. Surgery sometimes if the vegetations are large. Such as we see in Staph aureus or fungal disease. If the vegetations get to be 1 centimeter, then generally the surgeon is going to need to be involved, as is if the patient has a prosthetic valve endocarditis from Staph epi. Staph epi would be the most common organism in these patients, and they'll often need surgery as well, for sure, in order to heal this process. Otherwise, we monitor the CBC, the BMP, the SED rate, sometimes the CRP on a weekly basis. We make sure we've sterilized the blood culture right away because that'd be another reason to have surgery. These are difficult patients, very complex, and good luck with taking care of them. It's good to have a general framework as you look at this complex problem. Thanks, Dr. Gullberg, signing off.